first I'll introduce the people over here. I am Dr. Manavdeep Singh and Dr. Sushmita Kaushik, Dr. Arun Nayan Swami and Dr. Kavita. So we are the four people out here to judge the papers, and duration of each paper is 6 minutes. Membership number you will have to, I think, inform us, and only ratified members are eligible to get award. That is a number up to 26065.
Good afternoon, everyone. Thank you, AIOC, for giving me this opportunity. Myself, Dr. Fatima Noble. I'll be presenting on assessment of contrast sensitivity by Spieth-Richmond contrast sensitivity test in glaucoma patient. So as we all know, glaucoma patient describe their visual compromise as blurring of vision and needing more light to perform any task. While a glaucoma specialist will equate these changes with the visual field printout while communicating with the patient. But as the patient is confused, unable to correlate between vision and vision-related quality of life. Hence, a glaucoma specialist should include contrast sensitivity assessment for glaucoma assessment. Now, as we all know, around 30% of axons are lost before any defect appears on the visual field printout. This inadequacy of the visual field printout to detect early glaucomatous changes had led to attempt to measure by contrast sensitivity. We will be concentrating on Pelli-Robson and Sparks. Pelli-Robson contrast sensitivity test. It is a wall-mounted chart which is read at 1 meter with letters at constant size with decreasing contrast. 2 triplets of varying contrast are used, and the faintest triplet, in which 2 out of 3 letters are identified, a log CS value is obtained. But this measures only central contrast sensitivity, which is an inadequate measure for peripheral field defects. So we come to Sparks, which measures spatial contrast sensitivity in both central and peripheral visual field. So how is it done? It is performed on a standard computer on visiting www.sparks.com. On entering the basic information, the patient logs into the page. On entering the page, every patient will get its unique identification number, which can help the patient for the further follow-up. On logging into the page, the basic eye information is filled. On filling the basic eye information, the test is started. It tests the contrast sensitivity in central quadrant and in 4 peripheral quadrants. It is tested monocularly with patients seated 50 cm from the computer. On selecting the eye, the patient will see a vertical contrast grating in different quadrants while maintaining a central fixation. A score out of 20 is obtained for each quadrant, making a total score of 100. Patient for BCVA, slit lamp examination for anterior segment, intraocular pressure examination, posterior segment, visual field defect by Humphrey Field Analyzer, and contrast sensitivity by Pelli-Robson and Sparks. 174 eyes of 111 patient were analyzed, consisting of 87 in cases and control, equal distribution in gender and laterality, none of which affect the Sparks score. Mean age came to 56 years, and on pairwise analysis, intraocular pressure, cup disc ratio and disc damage likelihood score was more for glaucoma patient as compared to control. We also compared Pelli-Robson and Sparks score for different study group, and we could find out that the control had a higher score than the glaucoma patients. On univariate analysis, there was a positive correlation between Sparks and Pelli-Robson. On plotting an ROC curve for Pelli-Robson, it had a sensitivity of 83.9 and specificity of 59.8. Similarly, plotting an ROC curve for Sparks at a cutoff at 70 had a sensitivity of 83.9 and specificity of 96.6. On comparing the ROC curve for Sparks and Pelli-Robson based on perfect classifier, the Sparks was much nearer to the upper left quadrant, indicating a better performance. Now, all this study has been already done. What new this study adds? We also plotted an ROC curve for different quadrants like upper nasal, upper temporal, central, lower nasal and lower temporal, and we could found that the ROC curve and the area under the curve, sensitivity and specificity was much higher for Sparks as compared to Pelli-Robson. So we conclude that Sparks and Pelli-Robson tests demonstrate high degree of correlation, can be used interchangeably. Sparks is independent of effect of literacy in contrast to optotype based Pelli-Robson chart. And SPARCS measures both central and peripheral contrast sensitivity, which is better for glaucoma patient with peripheral visual field loss. So this was already known that SPARCS can be used as an alternative to pelliropsin test. This study adds that the current gold standard of contrast sensitivity needs to be replaced with a new and more accurate test like SPARCS. Thank you.
Hi, thanks. Nice paper.
Thank you.
Just a couple of questions. Whenever you present a study, you have to include ethics and you have to include informed consent. Both were
Yes.
missing from your. So did you take
Yes,
ethical?
ma'am. Everything was taken. Yes,
before?
ma'am. Yeah.
So that's not included. The other thing is that the same regions are not tested in both. So how are they comparable? You said that one tests the center and the other tests center and periphery. So how can you
Yes.
compare both because different regions of the retina have different contrast, we know that.
Yes, ma'am. So for all the patient with upper nasal quadrant defect,
No, but they are not being tested by pelliropsin, na?
yeah, they are not being tested. So this will give like the people who have a peripheral visual field defect, they came with a normal pelliropsin test or like a normal pelliropsin test result. But patient with SPARCS who had a very early nasal step or a peripheral arcuate defect, they showed changes in SPARCS.
But that's because pelliropsin is not testing the periphery.
The periphery, yes, that is the whole purpose of the SPARCS, ma'am. Yeah.
How could you say then that they can be used interchangeably?
Uh,
You said you concluded. How this conclusion could be drawn from this study?
pelliropsin was a gold standard test, so we could use SPARCS instead of pelliropsin. Right? They showed a correlation was positive correlation.
Any other judges? Any question?
Did you look at anything like a lens opacification score system before?
Yes, sir.
Okay.
Yeah.
Did you use some cutoff before
Yeah.
you thought the patient was eligible, because that can affect contrast,
Yes, sir. Yeah. So visually significant cataract, LOC grade 2, more than 2 were not included.
Good afternoon, everyone. Today, my topic of presentation is to analyze long-term visual field fluctuation among the eyes with moderate and advanced glaucoma. As we all know, the rate of progression these eyes is very slow, and it's important to detect true change to avoid any treatment delay. So, this test-to-test variation, we can which is a long-term fluctuation, we can measure it by using standard deviation, the threshold difference, or variance. Once the threshold value cross 15 to 19 decibels, it becomes difficult to detect further change because of the floor effect. So aim of our study was to calculate long-term fluctuation in patients with moderate to severe glaucoma. We have compared the eyes with progression and without progression, and we judge progression based on 10-2 PLR analysis. And we have included only threshold values which have average threshold value better than 20 decibel. So 53 eyes of 44 patients were included in this retrospective analysis. We judged progression severity of the glaucoma based on Anderson criteria. Haddox-Parrish Anderson criteria, we require minimum 5 reliable 10-2 visual field tests with minimum follow-up of 2 years. We have excluded any condition which could have affected the field test analysis. So for these are the baseline tests conducted for all the patients. So for all 68 points based on 10-2, for each point we calculated average threshold value, rate of progression including p-value, and standard deviation analysis. And we have marked the point as a progressing point if the threshold slope was worse than -1 decibel per year at p-value of 0.01. And we consider a field as a progressing even if there is a 1 point significant change. So as you can see in this diagram, the values which are marked in bold are the threshold values which were better than 20 decibels were selected. The red color values are the points which were statistically significant, and they showed higher fluctuation as compared to adjacent points. Statistical analysis was done using SPSS. So this is just to show the central view area represented the points which were taken as a central points, and rest were taken as a paracentral point. So total 13% eyes showed progression, 53% eyes were pseudophakic. When we compare the baseline parameters between eyes with progression and without progression, we did not find any difference. When we compare the baseline visual field parameter, the eyes with progression has better 10-2 mean deviation, and the rate of 10-2 MD progression was minus 0.59 decibel per year. So when we compare the visual field reliability indices between both the group, it was comparable. So how did we analyze fluctuations? We analyzed fluctuation based on global parameter, point-wise parameter among the eyes with and without progression. And for third group, we have just clubbed the points based on their individual characteristics, such as location, rate, and presence of progression. So what we found that first two group, there was no difference, and third group, we found significant difference in terms of fluctuation. So when we analyze global parameters, we did not find any difference between eyes with progression and without progression. However, progressing eyes has better 10-2 MD as compared to 24-2. So when we compare the total point-wise fluctuation, we did not find any difference in terms of fluctuation. When we tried to subgroup these patients based on location of the points and rate of progression, again, the both groups where median was comparable. However, when we went for the third group, where we just club points together based on characteristics, the progressing point definitely showed higher threshold. They showed lesser threshold values, higher rate of progression, and the standard deviation of fluctuation was 5.24 decibels, which was higher than the stable point. So when we compare the individual point based on rate of progression, the point which have rate of progression more than 1 decibel per year, they definitely showed higher standard deviation of fluctuation, which was around 5.61 decibel. And they definitely had a higher rate of progression and depressed threshold values as compared to the other points. So when we compare these points based on location, we did not find any difference in terms of fluctuation. However, the central point showed better threshold values. So discussion, the long-term visual field fluctuation based on global and point-wise parameter didn't differ between eyes with and without progression. However, the points which have shown faster and more significant rate of progression showed higher fluctuation. So the retrospective analysis done earlier have shown that the visual field fluctuation in normal patient is around 1.65 decibel, while in advanced glaucoma it was around 2.22 decibel. In our study, we found it around 2.9 decibel. So the range of fluctuation was noted to be higher in patients with severely depressed fields as compared in the retrospective study, where they found the difference was around 2 to 5.6 decibel. So the author concluded that since the central visual field fluctuation was less than 5 decibel and the cutoff for software analysis is 10 decibel. So in our study, we found that the progressing point which have shown higher fluctuation, indicating the focal nature of the disease among these eyes, which was not reflected in the global parameters. So these are my references. Thank you.
For the audio visual, can you give one beep when there's 1 minute remaining? Because I don't think the speaker knows.
No, we don't know.
Can you
get the timing over there?
No, sir.
Can you?
इसमें तो आता है
नहीं,
ना,
नहीं.
इनको नहीं दिखाई देता.
Ma'am, it's not a retrospective study. We have looked into another study where we compared the progression. So we specifically wanted to look into the severe glaucoma category patient, because these are the all eyes where it was not possible to detect progression based on the routine glaucoma progression analysis. So we wanted to see whether if we can judge it by seeing if the fluctuation is more. But surprisingly, we found that even the fluctuation doesn't give clue if you judge only based on the global parameters. So that means you need to go very focal in these eyes, because these eyes where a single point also means a lot to them.
You assume it is fluctuation compared to what? How do you know it's not progression? Because in the progression analysis, it is compared to a glaucoma of the same status, where the EMGT did 4 tests in 1 month, and they found that okay, within this is fluctuation. Anything more is progression. So what did you compare your 10-2 with? How do you know it is not progression, it is fluctuation?
But because these are the patients who have been doing field tests very routinely, so we do that learning effect, all those, there is less chance of bias, subjective variation, because it's all field test is more about the functional response.
Agreed. I'm just saying, how do you know the change is not progression and it's fluctuation? Fluctuation is okay, isn't it?
Yes, but it
The
would have.
progression is bad.
We have analyzed the rate of progression for individual point also, ma'am. So it should have reflected in that. We didn't go just by global parameter analysis. For each point, we have calculated the rate of progression.
Sure.
And we have used the De Moraes et al. Progression criteria.
Okay.
Respected judges and dear respected judges and dear colleagues, today's paper, glaucoma staging based on mean deviation of 24-2 visual field, underrated severity in visual field defect. Now, the purpose of this study to evaluate the accuracy of the mean deviation glaucoma staging system for classifying the severity of common glaucomatous visual field defects, particularly in central and peripheral defects in early glaucoma, and to assess the agreement between the mean deviation staging and existing two staging system, Hoda, Paris, Anderson, and glaucoma staging system 2 for classifying glaucoma severity. This retrospective cross-sectional study reviewed the records of 661 patients' data from 2008 to 2019, and we included 86 eyes of 72 patients with 4 common initial glaucomatous visual field defects, namely nasal defects, then central paracentral defect, partial arcuate defect, and arcuate defect. Now, all these included visual fields were graded initially by the mean deviation staging system and subsequently by 2 other classification systems, HPA and GSS2. Finally, the result of these 3 classification systems were compared. Now, these are the all staging systems. The mean deviation staging system entirely depends on the mean deviation scale, has the following 4 stages. Now, we adopted modified Hoda Paris Anderson system, and it has 2 main parameters, the mean deviation and the loss of threshold sensitivity within the central 5 degree of the visual field. HPA classification has 3 stages. Now, GSS2 plots the mean deviation on the x-axis and pattern standard deviation on the y-axis. The intersection between mean deviation and pattern standard deviation value defines its stage ranging from 0 to 4 according to severity. Now, in this study, the most common type of defect was nasal defect, 39.6%, then 26.7% partial arcuate, next was 23.3% central paracentral defect, and 0.5% arcuate defect. Please note here that the mean deviation staging and HPA staging classified almost equal percent of visual field defects at stage 1 and stage 2. However, the GSS2 staging was very dissimilar from both the mean deviation staging and the HPA staging. With 5 subdivisions, GSS2 had wider options for a detailed categorization of the visual field defects with a range from staging 0 to severe disease, so any possibility of misclassification is kept to the list by GSS2 staging. Now, table 3 shows the classification of disease severity of common glaucomatous visual field defects in early glaucoma by 3 existing classification systems. Now, we have noticed that the discrepancies among staging system in peripheral and central common glaucomatous visual field defects. First, we should consider the peripheral one. When 70% of the nasal and arcuate-like defects were classified by early or stage 1 by mean deviation and HPA staging system, GSS2 classified only 17% of the nasal defects, 11% of the arcuate defect, and 21% of the partial arcuate defect as early disease. Now, we observed the major difference among the staging system in classifying glaucomatous central visual field defects. All 20 eyes with central paracentral defect were classified as stage 1 or early disease by mean deviation staging. However, this classification was entirely different from the other 2 classifications. Here we see that is a central paracentral defect. Now, disagreement among all 3 staging systems for classifying this visual field defect, where mean deviation staging classified is as stage 1 and Hoda-Padis-Anderson classified is stage 3, whereas GSS2 classified it as stage 2. Now, Venn diagram illustrates the excellent agreement between mean deviation staging and HPS staging and poor agreement between GSS2 staging and mean deviation staging. Here is a chart shows the agreement-disagreement among staging system for assessing severity in central peripheral common glaucomatous visual field defect. In first row, we find it is a central paracentral defect. Here we find the agreement between mean deviation staging and GSS2 staging, but disagreement with HPA. Now, please note that this visual field defect with central paracentral defect was classified as stage 3 or severe disease by HPA. Why? Because HPA considers the abnormalities within the central 5 degree of the 24-2 visual field grid. Now, second row, we find an arcuate defect with high pattern standard deviation value 11.2. Now, agreement here we find it's the agreement between mean deviation staging and HPA staging, but disagreement with GSS2. Now, none of the eyes with arcuate-like defect in this research was classified as severe disease by mean deviation staging and HPA staging, but GSS2 classified 33% of the eyes with arcuate-like defect as severe disease, as GSS2 considered both mean deviation and pattern standard deviation for staging. Now, among 3 staging systems, only the HPA considers the threshold sensitivity of abnormal visual field point within the central 5 degree for staging the glaucoma severity. Now, hence, HPA staging classified 15% of the central paracentral defect as stage 3 or severe disease. Central paracentral defect were grossly underrated by mean deviation staging, and GSS2 staging as a damage within the central 5 degree was not considered by this method. Mores et al., they also observed that the current glaucoma staging system misjudged disease severity in the presence of
you
central...
have to pause for a second. ये 5 मिनट हुए, 6 हुआ है, 6 हो चुके.
नहीं 5 के बाद 1 हुआ था, पर बीप तो हुआ नहीं. वो तो अब हुआ है ना. मैंने आपको बोला था 5 पे बीप करिए ताकि स्पीकर को पता चले कि 5 मिनट हुआ है. 6 पे
आपने
तो
शुरू में
बीप हो ही
5 लगाया था ना इस पे.
नहीं, पर आप बीप तो 5 पे दोगे ना भैया.
1 मिनट पहले एक निशान.
एक बीप दो आप 5
Now you
मिनट.
quickly wind up, otherwise it will be over.
Mores et al. Observed that the current glaucoma staging system misjudged disease severity in the presence of central visual field defect in early glaucoma. So we could conclude that these findings suggest that the current glaucoma staging system, especially mean deviation staging, grossly underrates disease severity in visual field defects with defects within the central 5 degree and also nasal and arcuate-like peripheral visual field defects. GSS2 performed better for classifying nasal and arcuate-like defect. Hoda-Padis-Anderson staging performed better for classifying central visual field defect. A standardized staging system should be considered by clinician and researcher for quantifying both central and peripheral early glaucomatous defect to systemize the treatment. These are my references. Thank you.
Nice paper, Tutul, but you exceeded your time. Anyway, you tell me the question. Who studied these?
Sir, I studied it.
You studied, but this is not mentioned in this. No? There was a single leader for all these things and single person doing all this staging.
Yes, sir. This is a limitation. I did the whole thing.
Okay. नहीं या तो हमें दिखे या उसको दिखे यार. हम बिल्कुल opposite खड़े हैं ना.
नहीं, now he's understood.
No, but why he's again showing 5 minutes? Do you have any questions to ask? Anybody, any questions to ask? Any of the judges?
Good afternoon, judges, my seniors and my colleagues. My topic for today is the effect of assisted reproductive technology on IOP and CCT in women undergoing IVF. We do not have any financial disclosure, and ethical committee has given its approval and consent is taken in the patient's language. Introduction. Eye is the target organ for sex hormones, which is demonstrated by the innumerable number of sex steroid receptor mRNAs seen in various ocular structures. Pregnancy, which is a physiological high hormone state, affects the ocular morphology and visual functions through these receptors. Normally, in pregnancy, IOP decreases because of the increase in aqueous outflow under the influence of these hormones. Coming to artificial reproductive technology, it mainly addresses infertility, which includes IVF, ICSI, IUI, and IFT. The first step in ART is ovulation induction, which is done with a gamut of drugs, namely OC pills, GnRS analogs, gonadotropins, estrogens, which are given from day 1 to day 5 of the cycle, and injection HMG is given from day 6 to day 10, and injection HCG is given on day 12, and ovulation is checked on day 14. Administration of hormones exogenously, as in ART, influences the ocular morphology and visual functions, which are similar to those seen in pregnancy. Albeit, more and more women are undergoing ART because of the easy accessibility and success rate. So, it's important to know the effect of these drugs on IOP and CCT. The aim of my study is to know the effect of drugs used in ART on intraocular pressure and central corneal thickness in women undergoing IVF at a tertiary care center, a prospective cohort study. The objective is to compare the effect of these hormones on intraocular pressure and central corneal thickness in women undergoing IVF at the time of registration at ART center and after the completion of the cycle. Our study is a prospective cohort study conducted at a tertiary care center. 57 women were included in the study, and baseline ophthalmic examination was conducted for all the women. And IOP is checked with NCT and CCT is checked with OCT. Patients with prior ocular diseases and prior ocular surgeries were excluded from the study. Data was analyzed with statistical softwares, and a p-value of less than 0.5 is taken as significant. This table represents the general characteristics of the patients included in the study. The mean age was 27 plus or minus 3 years, and the duration of infertility was 5 plus or minus 2 years, and primary infertility was seen in 42 women and secondary infertility in 15 women. This table represents the IOP values before and after ART. Before ART, it was 16.2 and 15.6 in right and left eye respectively, and after ART, it was 14.2 and 13.5, and this IOP is the corrected IOP. This is the graphical representation of a decremental pattern of IOP after ART. This table shows the values of CCT before ART and after ART. Before ART, it was 521 and 519 in right and left eye, and after ART, it was 537 and 432, showing an incremental pattern. This is the graphical representation of the effect of ART on CCT, showing an incremental pattern. Coming to discussion, just as pregnancy causes physiological alterations in hormone levels, ART also induces similar changes that are comparable. According to Hoven and Joyens, a difference in mean IOP was seen in pregnant and non-pregnant women, which was statistically significant. They stated that IOP decreases in pregnancy due to the effect of hormones, and this is in accordance with my study. According to Park et al., who followed 24 pregnant women, they observed that the central corneal thickness was increased around second and third trimester, which resolved after delivery. Benge et al., Guthrie et al., and Sony et al. Also stated that corneal thickness is more around ovulation because of estrogen peak. ART drugs, which induce ovulation, also had the similar effect, and this is in accordance with my study. Finally, to summarize, CCT was significantly higher and IOP was lower in women after ART. So IOP and CCT should be measured as an integral part of ocular examination in women undergoing ART, and ophthalmologists must be aware of these changes.
How could you say this second conclusion? Can you show us the conclusions again?
The graphs, sir?
Conclusions.
Conclusion.
Last slide.
Right.
Second conclusion. IOP and CCT should be measured as an integral part. What is the indication? Why should they be measured? Because these are young patients, they don't have any risk of glaucoma.
Yes, sir. Because we took only the normal patients, sir, so in order to see the changes of effect of ART on the CCT, sir. CCT was around about 15 to 20 microns was increased, sir, after the ART use.
No, but how could you conclude this? Because these are normal physiological variations that will happen. They are of no clinical significance.
Yes, sir, but even in pregnancy also it is occurring, even with,
that's okay. We take that. But why you have recommended that it should be an integral part of the ophthalmic examination undergoing?
Because they are bringing about changes in IOP and CCT.
So what?
Because
physiological.
If the patient, if at all the patient is
no, you're not doing it in normal pregnancy, no?
We don't do it
We
in
are
our
not doing it
only in
so
the, because
in
nowadays
ART?
IVS has been increasing
It's
like
not
anything.
different. No, it's not different from pregnancy. Had it been different, then maybe this becomes an essential part. But once this is
It's
not
my just
different-
observation, sir.
this is an observation, but it
Yes,
should
sir.
not be a recommendation.
Okay, sir.
Thank you, ma'am. Good afternoon. सर मैंने यहाँ लगा लिया सर.
But correct. But it's
Good afternoon, everyone. Respected judges, I am Dr. Nilesh Kumar. My membership number is K20052, and I am here to present my work, Frugal Smartphone-Based Gonio Imaging Device, a Validation Study. These are my disclosure. I do have financial interest in the device that is being discussed, but we have taken utmost precaution that my bias doesn't affect the outcome. So glaucoma is the leading cause of irreversible blindness worldwide, we know, and we have 11.2 million adult patients in India, and India or Asia holds a unique position where open angle and closed angle are of similar proportion, not like West. And the only thing that can differentiate between open and closed angle is gonioscopy. But sadly, around 80% of junior residents do not perform gonioscopy, and 75% of those who perform are not happy with the skill that they have. And alarmingly, in US glaucoma clinic, 50% of the patient don't get a gonioscopy done at baseline. In US, where there is such low patient flow rate. So why it is so? It is because of the enigma of the gonioscopy, the dependency on slit lamp, the lack of trainer who train for gonioscopy, and the time it requires in a busy OPD. So what are the surrogates that are being tried? The Van Herrick technique, the AIOCT, UBM, the gonio imaging device from Nidec, and gonio pen. But all these techniques are not as accurate as gonioscopy. None of them has been proven to provide as good as information. So my research question was, can we find a rapid, reliable, frugal method to classify open and closed angle? So we devised a technique which we published in Journal of Glaucoma, where we used just a 4-mirror gonio lens and a smartphone to image all the 4 angles, and the quality was so good that it went on the cover of the Journal of Glaucoma. So this was our pilot study, our base for the current study. So we devised a device that is called Dix Pro. I'm not, this commercial aspect should not be taken care. The aim was to validate the image obtaining Dix Pro and the correlation of image obtained from this device with slit lamp gonioscopy. It was a prospective single-center, single-mask validation study conducted from April 2019 to 2020, and due to COVID, it was not presented elsewhere. The sample size calculated based on the pilot study was 222 image at 90% power and alpha of 0.05 for Cohen's-Kappa agreement. And with gradable image acquisition rate of 80% in the pilot study, we calculated 278 images were required to meet the minimum sample size. It was a single physician that did the slit lamp gonioscopy to grade the angle. Another masked physician performed the gonio imaging using Dix Pro. The 4-mirror gonio lens from Vogue was used for all the procedure, and 1+6 smartphone standardized across all the imaging. So the classification of image, the quality of image was classified into gradable and non-gradable based on the following criteria adapted from Azad et al. This was a study where ROP imaging was done using a smartphone, and we took the same criteria where landmarks were identified and how clearly they were visible. And Schaeffer's classification was used to classify open and closed angle glaucoma. The physician performing gonioscopy graded the gonio images on a later date, and the images were masked to remove any personal information. Another grader who also graded the gonio images separately, so that we have inter-observer agreement as well. All data was entered into MS Excel and was expressed in percentages, and then IBM Spaces version 23 was used to calculate the Cohen's-Kappa coefficient. Sequential images were obtained to attain a sample size of 280. Out of 280 images, 250 images against the 220 of minimal sample size were found to be of gradable quality. And true to our Indian population, 55% of these were classified as open angle and 44% were classified as closed angle. on slit lamp gonioscopy, not on the imaging device. The intra-observer agreement, so the person who graded on slit lamp and on the device, the intra-observer agreement was 0.65, which signifies a substantial agreement, and the inter-observer variation between the two graders who were grading for DIX Pro images was 0.82, which also signified a substantial agreement, and 91.6% agreement was found between the level of pigmentation noted on slit lamp evaluation in gonio images obtained from DIX. So these are some other, apart from open and close angle, we could image angle recession with hyphema, iridolalysis cleft. A glimpse of disc was also found. Peripheral anterior synechia, beautiful hill we could image. Sam-Palsy line and plateau iris configuration, some silicon inverse hypopia on silicon bubble and synechia. So gonioscopy is an essential component of glaucoma diagnosis that determines the line of management. The current study provides a cost-effective, frugal, innovative technique to screen for open or closed angle of the anterior chamber. It provides a clear gradable image in 80% of the photographs. Our study reveals a prevalence rate of open angle at 55% and rest in some form of angle closure. The study population was Indian population, so it correlated. The limitation is that it is a flash-based diffuse illumination that may induce pupil reconstruction. It is a theoretical consideration that limited our study. To conclude, DIX Pro is a new frugal innovation that can help in screening the patient for anterior chamber. It is not a diagnostic thing. It is just to screen at grassroots level. Good quality images can be obtained to segregate the patient that might need further evaluation in the clinic, and these patients can be further counseled and treated based on their disease burden. Thank you.
Any of the judges, any questions?
So what is you said it's a frugal innovation, and what is the real cost of this device, including the smartphone?
25,000 is the device cost, and the smartphone, any smartphone which anybody is having can be used. Single camera, multi-camera, Apple or Android, anything can be used, and it is compatible with 2 mirror, 3 mirror, 4 mirror and 6 mirror from all the major companies, including the Indian make and the imported one from Vogue or Oculus.
Can you show us the slide 23 once again?
So yeah,
Slide number 23. So this you said is a flash-based diffuse illumination.
yes sir.
So this will anyway open the so many.
This is the major criticism that we keep facing
How can you
whenever we
use it
present,
as a
sir.
screening device?
Yeah, sir. We went back because we actually, the data was saying that there is a good correlation that is happening, and it was masked. It was not because both the observer who were included, they don't have financial interest in the device. So I was not involved in the trial. Somebody else did the trial for me. The pupil constriction lag time is 0.3 seconds. So when we shine a light, the pupil starts constricting after 0.3 seconds, and the entire imaging takes place in 0.1 second. So the flash that is being projected and the image being taken is all within 1/100th of the second. So before the pupil starts constricting, we have taken, and we have a proof. It was not in the part of the free paper, so I have not presented, but we have used slow motion videography. So we switch on and switch off the flash and do a slow motion videography, and we can see the pupil reconstruction happening that is being recorded.
So you can do some future.
Start. So good afternoon everybody. Today my topic is an amniotic membrane umbilical cord graft reflecting new rays towards the glaucoma shunt surgery. I have no financial interest. Glaucoma drainage devices more frequently used in the treatment of uncontrolled glaucoma, and the tube exposure is the serious post-op complication that increases the risk of intraocular infection. Several patch graft used for covering the tube shunt, glaucoma shunt tubes, and the tube exposure rate reduced from 30% to 5% for the first 1 to 5 years, and the incidence of significant thinning and the melting of the graft 15% to 25% within 2 years post-op, and it is probably due to immune-related process and poor host tissue integration. So the why MUC graft used, harvested from the umbilical cord with its compact structure and overlying amniotic membrane, high tensile strength, low immunogenicity, and excellent host tissue integration significantly reduce the graft thinning. So this is the video that showing how the umbilical patch graft is processed from the donor tissue, and it is available as an amnio plus thick, and that is sterilized, minimally processed, dehydrated super thick human umbilical cord derived membrane allograft with a thickness 300 micron. And this is the histological pictures that shows the devitalized epithelium, compact stoma, and the basement membrane. And this graft is registered under Human Organ Transplantation Acts. So the objective of the study to determine the safety and the efficacy of amniotic membrane umbilical cord graft in glaucoma shunt surgery for reducing the glaucoma shunt tube exposure. It was a hospital-based prospective non-comparative interventional study and approved by the Ethics Committee of Institution and registered at Clinical Trial Registry India. Inclusion criteria: patient who had an uncontrolled glaucoma with or without failed trabeculectomy and the age 40 to 50 years. Exclusion criteria: previous GDD surgery, chronic ocular inflammations, and no PL. So the method: the 50 eyes of the 50 patient with a refractory glaucoma underwent glaucoma shunt surgery using Ahmed valve, and the tube is inserted into the anterior chamber and the pars plana, and the tube are covered with an AMUC graft, and the period of study 2.5 years in RIO Kolkata. So this is the surgical technique. The first, before implantation, the graft was rinsed and reconstituted with a balance on solution 20 minutes before surgery, and then cut into the rectangular shape 5 mm into 7 mm, and then it's placed over the tube portion of the valves and secured to the underlying sclera with a 90 nylons. So now come to the follow-up. The patient were examined on the first post-op day, then 1 week, 3 months, 6 months, 12 months, 18 months, and continue. And the ASOCT were assessed to assess the patch graft thickness, stability, and the host tissue integrity. So the main outcome measure including the tube exposure, graft thinning, and the graft-related complication, and the secondary outcome measure other complication related to the tubes. So the early graft thinning is defined as more than 20% reduction of the graft thickness at 3 months. So this is a subjective demographic and the preoperative characteristics. Now come to the result. Out of the 50 patients, the 6 patients develop early graft thinning, and the 2 patients develop late graft thinning, 1 patient developed tube erosion, and none of the patient develop any complication. So this is the changes of thickness of the AMUC graft. At the 1 month, the is 40 micron and average thickness, and the 18 month the average thickness was 274 plus minus 15 micron. So this is the sequential ASOCT picture. At the 1 month, there is a gap between the patch grafts and the conjunctiva, and within the 12 month, the graft is well marked with a subconjunctival space with a maintained thickness and increased reflectivity that indicates the excellent host tissue integrations. And the 12 months, the AMUC covered area is an aesthetically more appealing. So this is an ASOCT picture of the tube exposure. And next is a sequential ASOCT that's showing the late graft thinning. So as per the published literature, several patch graft used for covering the glaucoma shunt tube surgery, the donor sclera tube exposure 26.8% in 2 years, and the endophthalmite is 1.7%, donor pericardium tube exposure 7 to 15%, and progressive thinning 28%, amniotic membrane tube exposure 3.43%, and the corneal patch graft tube exposure 2.5%. So the AMUC patch graft, the tube erosion is 2% and endophthalmite is nil. So this is another study that was published in Ophthalmology Glaucoma 2019, and the purpose of the study to compare the long-term safety and the efficacy of the amniotic membrane umbilical cord and the pericardium patch graft in reducing glaucoma shunt tube exposure. So the conclusion of the result of this study is tube exposure occurred in the 2% in the AMUC group, and the incidence of the early graft thinning only 12%, left graft thinning 5%. In my studies, the 18-month follow-up, early graft thinning 12%, left graft thinning 4%, and the tube erosion 2%. So the AMUC grafts are well tolerated, and its high tensile strength, low immunogenicity, and the excellent host tissue integration property, excellent long-term graft survival. And this is a treatment of option especially beneficial in the limited donor cornea and the eye banking services. These are my references. Thank you.
One thing, you are already a faculty member in a medical college. In PPT, you have put full stops everywhere. Don't you know that they are not supposed to be put?
This is not. Other presentation.
Full stop is supposed to be used when there is a complete sentence and in case you are writing a text. And in PPTs you are supposed to make only points.
Sir, this is not the original presentation. Oh, there's some mistake.
No. Chalo, anyway, that's for us to judge. But any
So, what was your, like in your own institute, before you used this graph, so you were using sclera, must have been using
A scleral patch graft also
what was
used.
your tube erosion and exposure rate? You compare your own rates with this rate rather than compare it with the
Yeah. The tube erosion rate is more in the scleral patch graft, and there is also endophthalmitis is more in scleral patch graft.
what is the rate?
Incidence rates are more than 15% in tube erosion.
How many years after research?
I have done 3 years. 3 years surgery.
Why that would have been better like if you
Yes, the COVID situation when there is a scarcity of the eye banking.
other factors which determines the tube exposure, especially like
Tube exposure,
entry size.
yeah, and the especially tube exposure more occur in patient with an chronic uveitis, so secondary glaucoma. This patient may have more prone to develops, and also the patients who had a number of multiple surgery previously done, and also in my study I seen that there is a female object more prone to develop tube erosions.
you have shown 26% as a tube exposure incidence, which I can't digest because
Yeah.
I have been doing walls. I think I must have done more than 150 walls by now, and I have seen tube exposure in my cases only in 3 cases.
But
And,
this literature said
and I have been doing it for a very long time. I have a long, follow up. And then generally, those 3 cases also which I had, they were only in the beginning. There's only one case in which it really melted, the sclera melted, maybe some autoimmune reaction and all this happened. But at 26% of incidence is very difficult to digest.
Respected judges and friends, welcome to the post-lunch session. I'll be presenting a very small series on a very important problem on outcomes of IZHV in acute intraoperative aqueous misdirection. The study was a retrospective institutional review board approved study where we looked at the EMR and interviewed cataract surgeons to find patients who had acute intraoperative aqueous misdirection characterized by acute shallowing of the anterior chamber with iris prolapse, inability to inject viscoelastic, forward movement of the lens, intraocular lens, or the bag in presence of a normal fundal glow, and after external factors were ruled out, which underwent IZHV and followed for at least 1 month period. We noted the diagnosis, the ocular findings on the slit lamp and fundus examination, the visual fields, biometry, the surgical plan, and reviewed the surgical video wherever it was possible, along with interviewing the faculty on the course of the events. And special attention was paid to the step at which shallowing happened and the countermeasures taken by the surgeon. On follow-up, special attention was paid to the anterior chamber depth centrally and peripherally. The external factors which were ruled out, some of these will be there right when you begin the surgery, but the ones highlighted can occur anytime during the surgery. So the speculum was checked and loosened if tight. Patient was spoken with and made sure that the patient is not coughing or sneezing or not holding the breath, is not straining with a full bladder. Fundus glow was examined to rule out suprachoroidal hemorrhage and choroidal detachment. And then an IZHV was performed as required. Looking at the baseline characteristics, 4 of these 7 surgeries were combined cataract and trabeculectomy, and 3 were phacoemulsification. 5 of these patients had angle closure disease. The patient with pseudoexfoliation had a coexisting occludable angle. 5 of these patients had raised intraocular pressure, and they were on multiple medications ranging from 0 to 5. The axial length was pretty much within normal range, except 2 patients, one of whom had a shortish eye of 20.65 millimeters and another a high myope. The lens, though not being extraordinarily thick, was on the thicker side. This is one of the examples of such a patient when one began the surgery normally, but during irrigation aspiration, I realized that the posterior capsule is coming up so much that it's bulging beyond the rhexis margin, and it was becoming difficult to do aspirate the cortex with safety. Attempts to fill the eye with viscoelastic did not result in any improvement. The speculum was loosened, patient was not coughing, straining or breathing heavily, and any attempts to deepen the anterior chamber only pushed viscoelastic out of the eye. This was suggestive in presence of a normal fundus glow of acute intraoperative aqueous misdirection. So upon checking the tension also of the globe, which was very hard posteriorly, the diagnosis was confirmed. And when nothing else could happen, I proceeded with a IZHV. A 26 gauge Alcon vitrector on the Infinity machine was used to create an iridectomy first, then to eat capsule or zonules whichever lie in the periphery, till the point of time when there was a sudden shallowing of the anterior chamber, and everything then became easy. You will see the reverse pupillary snap sign right now, and I will just show that sign again, which basically represents the point of time when the anterior hyaloid face has ruptured. And thereafter, the surgery was performed with complete ease. You see the anterior chamber seems to be well formed, and there is no more problem. I just want to highlight the settings of vitrectomy while performing IZHV. This I have not seen being documented anywhere. This is derived, not completely written, copied from the Alcon manual. So the basic principle is, while doing iridectomy, you be in IA cut mode, use the lowest possible cut rate so that you have control on the shape and size of the iridectomy. This iridectomy should be performed ideally at a site where there is no incision, so that a laser, if required in the post-operative period, can be performed easily. The next two steps are performed with the cut IA mode with highest cut rate. So on follow-up, we realized that all of them actually, that the aqueous misdirection happened at a stage when the AC had actually shallowed, and on follow-up, all of these had normal intraocular pressure, some of them on multiple medications. Only one patient required additional laser procedure for a recurrence, and the post-op regimen that was given to them, practically the most important aspect was using atropine and tropicamide phenylephrine combination, both carefully being tapered stepwise over a period of 2 to 4 weeks each. These were the steps that we followed. The confusion in naming is also reflected in the confusion in management of this situation. The latest review article mentions that pars plana decompression should be performed either with a needle or through the pars plana approach. But this is very similar to the Chandler's procedure, which is decades old. We anterior segment surgeons and glaucoma surgeons have to take control in our hand and get the capability of performing a safe and effective IZHV through the anterior chamber. The limitation is that is it small series for a rare thing, suboptimal visual acuity we cannot explain, and lot of medications were required. Angle closure glaucoma and raised intraocular pressure seem to be risk factors. The strengths of the study are that this is the first series on IZHV through anterior route in acute intraoperative aqueous misdirection. This has been published for chronic aqueous misdirection, but not for acute setting, and none of the patient record showing the efficacy of the procedure. Thank you so much.
First thing is how safe it is, because this looks very unsafe compared to you. You are from an institute where retina VR surgery is easily available. Why did you not go through the pars plana and went through the anterior route?
Actually, this is
this looks very unsafe.
That's what I wanted to say, that this is not unsafe. I have been doing this. I have seen people do this for many years now, but it was not getting documented earlier. And lot of surgeons do this for chronic aqueous misdirection. So if you see the 7 patients done over a period of 3 years, none of them had any complications because of the procedure.
And did you confirm all of them did not have any choroidal hemorrhage or choroidal detachment?
Yes. So the immediate resolution of the anterior chamber depth and intraocular pressure and a fundus examination that is routinely
No,
performed.
did you do post-operative ultrasound for these patients to confirm that they were not the case of vitreous hemorrhage? Sorry, a choroidal hemorrhage. Did you rule that out?
B-scan was upon resolution with an IZHV is an indirect proof of aqueous misdirection.
No, but you could have confirmed it that this is not choroidal hemorrhage. That's a confirmatory, na? Confirmatory will be done only by ultrasound.
But even a dilated fundus exam could have been
so
good
that
enough.
we
So you would
routinely
have done it in a way.
Yeah, that we routinely do for every patient first post-operative. All patients.
I'll be talking about in vivo imaging of Schlemm's canal and the management of juvenile open-angle glaucoma. I have no financial disclosures. In JOAG eyes, it has been previously seen that those eyes which have features of angle distances on gonioscopy, they usually respond poorly to selective laser trabeculoplasty and medical management. Our group also previously published that those eyes which have a gonioscopically normal angles, they may have angle distances on AIOC2023, and when this is present, these eyes respond poorly to selective laser trabeculoplasty. How this angle distances is evaluated, I'll be discussing subsequently. So the objective of the present study was to evaluate the presence of angle distances on AIOC2023 as a predictive factor for overall management of JOAG eyes. It was a prospective clinical cohort study with 18 months follow-up. Written informed consent was taken, and it was. Yes, sir.
Please start.
Sure.
Objective will start with the timing. Okay, just show me the objective. Okay, now we start with the again. Okay, please start.
Good afternoon, everyone. I'll be talking about in vivo imaging of Schlemm's canal and the management of juvenile open-angle glaucoma. I have no financial disclosures. So in juvenile onset open angle glaucoma eyes, it has been previously seen that those eyes which have angle dysgenesis on gonioscopy, they respond poorly to selective laser trabeculoplasty or medical management. Our group has previously shown that those eyes which have a gonioscopically normal angle, these eyes may have angle dysgenesis on AIOC2023, and when such angle dysgenesis is present, they respond poorly to selective laser trabeculoplasty. The objective of the present study was to evaluate if presence of angle dysgenesis on AIOC2023 can help as a predictive factor for overall management for JOAG eyes. It was a prospective clinical cohort study with 18 months follow-up. Written informed consent was taken from all the participants, and it was approved by the Institutional Review Board. Those JOAG eyes were only included that had no angle dysgenesis on gonioscopy. They underwent angle evaluation at onset. They were divided into 2 groups which had dysgenesis and which did not have dysgenesis. All the eyes were offered medical therapy first, and only those which showed failure underwent filtration surgery. So how angle dysgenesis was evaluated? It was a SGOCT machine with the modified angle module, and we used the enhanced depth of imaging. 50 B scans, that is 30 degrees of angle, was only evaluated. 25 B scans, that is 15 degrees angle each in the nasal and the temporal quadrant. It was assessed by 3 blinded glaucoma specialists, and angle dysgenesis on AIOC2023 was defined as an absence of Schlemm's canal or a presence of hyperreflective membrane. I would like to point that Schlemm's canal was defined as the well-demarcated hyperlucent space within 350 microns perpendicular distance from the trabecular meshwork, and it had to be present on at least 2 consecutive B scans to differentiate it from an artifact. Further, one blinded glaucoma specialist also tried to quantify angle dysgenesis by counting the number of AIOC2023 B scans in which Schlemm's canal was present. On the left-hand side, we can see normal morphology of Schlemm's canal that was seen in this study. On the right-hand side, in the upper image, we can see an absence of Schlemm's canal. In the right lower image, there is an absence of Schlemm's canal along with presence of a hyperreflective membrane. out of 75 eyes that were initially recruited, we had a loss of 9 eyes had to be excluded because the angle could not be captured properly. So we had 66 eyes which underwent the medical management. Out of them, 35 had success and 31 showed failure. The agreement between the 3 observers was good, which was statistically significant. So those eyes which underwent surgical management had a lower age at onset. They had a more severe disease. The baseline IOP was higher, and the vertical cup disc ratio was higher at onset. The last 3 features were statistically significant. On evaluating the angle, we saw that when Schlemm's canal was present on any consecutive B scans, 72% of eyes had successful medical management. When the same thing was quantified and we defined that Schlemm's canal should be present on at least 50% B scans, 90% of these eyes had success of medical management. When hyperreflected membrane was present, all the 11 eyes showed failure, and they had to undergo surgical therapy. So this graph shows that all the eyes in which angle dysgenesis was present, they had to undergo surgical therapy. On regression analysis, the only significant factor which out of everything which was found was presence of Schlemm's canal, and it increased the odds of success of medical management by 2.9 times. So the absence of Schlemm's canal and ASOCT is a strong predictor for failure of medical therapy in JOAG eyes, and it can be used to tell the need for trabeculectomy or other filtration surgeries in these eyes. The clinical relevance, other than clinical decision making, is also prognostication and patient counseling at onset. The future applications based on the previous data, we came up with this proposed treatment algorithm where we say that if angle dysgenesis is present on gonioscopy or it is present on ASOCT, these eyes will require surgical management. So the patient can be counseled regarding the same, and the surgeon should be aware of this. And those eyes which do not have any angle dysgenesis, either both gonioscopically and on ASOCT, they may respond well with medical management. The limitations of the study was that high resolution scans could not be obtained in all the eyes, which I said 9 eyes we could not include because they had poor scan resolutions. Also, 360-degree angles should have been imaged to quantify the dysgenesis. However, 30-degree angle imaging also had correlated well with the results. We did try to image 360-degree angle in 4 eyes, but it took 2 hours per eye, so we stuck to 30 degrees. Thank you.
Dr. Toshit, what is a cohort study?
So a cohort study is in which we divide the group in which at onset we divide the population which we are studying into 2 groups or any number of cohorts which we want, and we see the outcome of any intervention or any risk factor in them.
No. Intervention becomes a trial.
Yes, sir. Intervention becomes a trial, sir.
No, this is not this. I don't think this is. Do all the judges agree with me? This is not a cohort study as mentioned in the paper here. This is not a cohort study. This is an observational study. You can see.